at 0.6. So hazard ratio of the overall survival at the second interim analysis was 0.67, suggesting a 33% benefit of pembrolizumab arm in this A18 trial versus placebo. So remember, this was a hierarchical analysis where we did the first interim analysis, and because it was positive, the second interim analysis is really a descriptive one and not really analyzed in terms of the trial. So here in the overall survival subgroup analysis, other than over 65 years of age, majority of them benefited, irrespective of the kind of radiation therapy. I must mention that there was quite an impressive radiotherapy given in this trial. It was planned to be given within 56 days, and which in the pandemic and which in the being a global trial was quite an achievement. So this is as good as a trial that you can see, really. So one of the secondary endpoint was overall response rate and response duration. And again, you see that both the duration of response and the overall response rate is in favor of pembrolizumab arm. Now looking at the adverse events, if you look at the left side of the screen, greater than or equal to grade 3 in pembrolizumab arm was 78.2% versus 70% for placebo. So there was no new signals, and it was quite well balanced in terms of adverse events. There was no major difference. The serious adverse event was only 4%. Obviously, you're going to add pembrolizumab to radiation therapy, and you know that when you add radiation therapy to pembrolizumab to radiation therapy, the effect of radiation is improved, and hence the side effects. And obviously, there's immunotherapy side effects. So this is really negligible. And there was 0.9% deaths in pembrolizumab arm versus 1.3% deaths in placebo arms. What was interesting was that 20.6% in pembrolizumab arm discontinued any treatment, but only 0.2% discontinued all treatment. So majority of the time, it was really the pembrolizumab arm that was discontinued, and CCRT went ahead as planned. So at the minimum, they had, the standard treatment at the time. And similarly, as expected, immune-related side effects were more. Now, these were the immune-related side effects. You would expect hypothyroidism, hyperthyroidism. The concern at the beginning was obviously colitis, because radiation colitis and immunotherapy colitis was supposed to be concerned. But if you look at that, there was no major difference. So in summary, pembrolizumab combined with modern high-quality concurrent chemoradiotherapy and continued after concurrent radiotherapy provided statistically significant and meaningful improvement in the progression-free survival. In the first interim analysis, in the second interim analysis, it even got better versus the CCRT alone. For high risk, stage 1B, 2 to 2B with node positive, and in 2014 classification, which in 2018 classification would be stage 3. And safety profile was quite manageable. And this is going to be an appropriate control arm in future clinical trials. So if the host allows me, I would like to make the floor open for any question and answers. And if there are no major question and answers, I'd like to talk about the other locally advanced trial and how does it compete with that one.
We haven't got any questions at the moment. Maybe we can carry on, and in the end, we can now open the floor for discussion.
Okay. So this is a locally advanced cervical cancer treatment. As I said, for 20 years, it was concurrent chemoradiotherapy, but more recently, there was a UK-based trial, when I say UK-based, majority UK recruitment called INTERRACE, where they gave induction chemotherapy, followed by concurrent chemotherapy, and how does it fit in to that? And very shortly after Interlace trial came this approval for pembrolizumab arm. So this is something that was a question for all medical oncologists and radiation clinical oncologists as to how do we change our practice and where do we put these trials. So I've got some comparisons looking at it in detail. Basically, in short, Interlace trial was really a UK-based trial with half the number of patients recruited, around 500 as opposed to 1,000. It was mainly a low-risk group, and it took a long time. As I mentioned earlier, this pembrolizumab, the A18 trial, took a couple of years in pandemic, while this Interlace trial took around 10 years. And during 10 years, correct me if I'm wrong, clinical oncologist, but the radiation therapy changed from 2D to 3D in a lot of centers. Also, in Interlace trial, 70% of patients were from UK. It's difficult to say which ethnic origin, and 20% were Mexican, while as I suggested in A18, 30% were Asian, and it was a global trial. Thirdly, in A18, 85% of the patients were node positive, and there was 23% above the aortic arch, so para-aortic nodes, while in Interlace, majority were early disease, around 67% were early disease, but only of stage 1 and 2, and the node positivity was only 52, all below the aortic bifurcations. Anything above the aortic bifurcations, above 1.5 centimeters, was not allowed. So A18 was really a high risk group, while Interlace was a low risk group. Obviously, you cannot compare two different trials, different backgrounds, different type of patients, but that's what it is. So any questions now while I take a sip of tea?
Sajid, sorry, apologies. I think your slides are not progressing. You might need to look into that. You are still on summary and conclusion. We're talking
No,
the
no,
next
I
one.
wasn't. I didn't have. This was sorry. This was extempo. There was no slides. So this was my own summary of comparison. Interlace was not.
Okay.
It wasn't.
Thank you. Thank you.
I would just like to add, obviously, it is a big question for the oncologist, whether to take the practice to Interlace as per the Interlace trial or Keynote A18. As Dr. Durrani said, there are few areas where we are not very clear about Interlace. Obviously, it's just an abstract which was presented in ESMO 2023. We haven't got a full text or the complete clinical details even about radiotherapy in the Interlace trial. But we understand that Interlace, as Dr. Durrani said, it included the patients who had conformal radiotherapy as compared to A18, where all the patients had intensity modulated radiotherapy treatment. And over the last 20 years, there has been marked improvement in the radiotherapy techniques, which indicated that there was an improvement in the overall survival and progression-free survival for these patients, including the MR-based brachytherapy treatment. So it's pretty unclear. Obviously, there were low-risk patients in the Interlace trial, along with the fitter patients who were eligible to have chemotherapy. So not very clear, but I think in the coming months, the practice will be moving towards immunotherapy. Just looking at the questions. Yeah, so they said Nouri, in Nouri, Islamabad, they are doing mostly IMRT followed by brachytherapy, which I think is now the standard of care for all the cervix patients. Okay, should we move forward? We haven't got any questions yet.
Good. So, okay, let's move to metastatic cervical cancer. I'll be a bit quick. I'll whiz through this one because we have already had a trial about metastatic cervical cancer last year, similar immunotherapy. So this was BEAT-CC. Leslie Rendell presented it. This is the first PD-L1 inhibitor in metastatic recurrent first-line cervical cancer. Now, 2014, Professor Tawari presented this data, and we had to wait a long time for metastatic cervical cancer to improve from chemotherapy to addition of an anti-VEGF or a novel treatment. And the overall survival improved to 17.5 months with the addition of anti-VEGF, which makes sense because there's synergy between checkpoint blockage and bevacizumab and anti-VEGF. So then it took another 7 years in the Keynote 826, which improved progression-free survival and overall survival with anti-PD-1 added to platinum-based chemotherapy. Now, in this trial, which was presented a couple of years ago, bevacizumab was optional for recurrent metastatic cervical cancer as first line, and that improved overall survival further to 26, now a little above 2 years in all comers. So BEAT-CC is the first global phase 3 trial, which is not just looking at anti-PD-L1 and with a mandatory bevacizumab, platinum-based chemotherapy in the recurrent metastatic, irrespective of any PD-L1. So the patients were recruited irrespective of PD-L1. So that's how they were randomized. The baseline, basically, there's metastatic, persistent, recurrent cervical cancer, ECOG less than 1, no prior anti-cancer treatment. Interesting point was that they did not allow bladder or rectal involvement for patients who had pelvic disease, because obviously with bevacizumab, which was mandatory, there was a risk of fistula, and PD-L1 expression was available for archival sampling. Randomized 1-to-1 to standard platinum paclitaxel bevacizumab as the control arm every 3 weeks, with the addition of bevacizumab in the experimental group arm, and it was continued until progression. If the patients had CR after 6 or more cycles, they could stop chemotherapy, and biological therapy would continue. And crossover from standard arm at progression was not permitted. So dual primary endpoints, investigator assessed progression-free survival and overall survival. Key secondary endpoints were overall response rates, duration of response, time to first subsequent therapy, PFS2, and obviously safety. So baseline characters were well balanced. You see that most of the patients here are Caucasians, but there were some Asians. Most 80% was squamous cell cancer, 20% been adeno or adenosquamous, 73% were recurrent cervical cancer, 21% were de novo, again distributed between different stages, with 34% distant only disease and 50% pelvic and distant disease. Primary chemotherapy, concurrent chemoradiotherapy concurrently had been received by 34%, surgery followed by this CCRT in 31%, and no treatment in 27% of patients. So this was the first dual primary endpoint, which is progression-free survival. And you see that there was 38% reduction in the risk of progression or death when bevacizumab chemotherapy was given with atezolizumab, as opposed to just standard chemotherapy and bevacizumab. At 36 months, the PFS was 26% for the atezolizumab arm and 12% for standard arm. So then second dual primary endpoint was overall survival. Again, statistically significant 32% reduction in the risk of death, with a 36 months progression-free overall survival of 42%. in the atezolizumab versus 26% in the standard arm. So this is the protocol specified subgroups. And as you can say, irrespective of all the pre-specified subgroups were benefited in patients who had atezo, as opposed to just standard chemotherapy and bevacizumab only. Safely, obviously, in the previous trial, which I referred to earlier, the 826, the keynote 826, which looked at another pembrolizumab, arm. Sorry, just admitting somebody here. Where's my cursor gone here? Okay, so in 826, which was presented, I think, a year ago, essentially, bevacizumab was mandatory, and only 60% of patients had bevacizumab. And the concern was that if they had bevacizumab with immunotherapy, there would be serious side effects, to such an extent that the investigator had to do exploratory analysis, really, to show us that even those patients who did not have bevacizumab were also benefiting. So the strength of this trial really is, other than being the first PD-L1, secondly, that it was irrespective of PD-L1 status, but thirdly, and most importantly, that all of the patients got bevacizumab, and despite that, yes, there were some more toxicities, but not really different. If you look at the left and the right, adding bevacizumab is 79% grade 3 toxicity versus 75%. They were smart in excluding, bladder and bowel involvement, but that's what they needed to do. So not a major difference, really. So 80% were grade 3, but only 15% discontinued treatment. And only 3% died. If you look at compare the statistics again, with a bit of caution, you can't compare cross trials, but death rate was slightly more in keynote 826, and more patients led to discontinuation in keynote 826, and despite having less bevacizumab. So keynote 152, before the keynote 826, was really what got FDA approval in 2018 for somebody with metastatic cervical cancer who's not had chemotherapy or immunotherapy before, and CPS score was greater than 1, and that was in 2018. So we wait to see if atezolizumab would be equally, would they get a FDA approval irrespective of the PD-L1 or not. But in 2021, EMA has already approved immunotherapy regardless of PD-L1. Talking about metastatic cervical cancer, the company had submitted to FDA for approval, but due to some unknown, nobody knew how they took their thing back. Even I asked Thomas Jared, who's the GOG head, and he kind of evaded the answer, saying, it was this was political and whatever. So I'm not sure why they took back their request, but certainly EMA has approved it for PD-L1, irrespective of PD-L1. So I think that's the summary and conclusion. So BEAT CCC confirms the clinical benefit of immunosuppression and angiogenesis and recurrent metastatic cervical cancer. Adding anti-PD-L1 to bevacizumab plus chemotherapy improves progression-free survival and overall survival significantly by above 30%, and meaningful improvement in objective response rates, a longer duration of response, and a longer time to first subsequent therapy in PFS2. And the suggestion was to add atezolizumab to bevacizumab with platinum-based chemotherapy. It's tolerable and does the trick. So I think that's any questions before we go ahead?
There's one question about Keynote A18. And they want to know, when do we start pembrolizumab with the chemoradiotherapy? Is it in week 1?
So yes, there is no lag, of concurrent chemoradiotherapy. So it's given every 21 simultaneously with the start of radiation therapy and chemotherapy.
Yeah, so I believe there are 5 cycles, weekly cycles.
That's right, 5 3-weekly cycles. So 5 3-weekly cycles.
5 3-weekly cycles.
Of pembrolizumab, starting with day 1 of CCRT, and then after that is 6 weekly. I guess practicality is going to be a bit difficult. We have an EPIC here, so we can, I'm sure there used to be chemo care, and those who have got chemo care, it should be easier to get hold of your chemotherapy and pembrolizumab. But if it's handwritten in practice, it's going to be difficult to catch patients all the time. But obviously you'll have to look out for them, and it's best that you do what the trial has done as opposed to making your own. Not that it's going to make any difference, I feel, but still.
Yeah. Thank you. Yeah, we haven't got any further questions.
Okay, so just a bit of breather. These are 2 posters, and I'm going to take a few minutes. No trials, but what do you do after immunotherapy for cervical cancer? So there's drug antibody conjugates coming. Tisotumab vedotin is FDA approved. AMA is coming soon. So post pembrolizumab, that's something should be considered. And for the sake of time, I've not gone into that. Then HER2, anti-HER2 with objective response of 50%. And for those who have got immunochemistry 3+, trastuzumab deruxtecan TDXD has a 75% response in metastatic cervical cancer, those who have had immunotherapy and standard treatments, and also impressive progression-free and overall survival. Then is a TROP2, SASI, or suscetinib govitecan. Expression is more in squamous as opposed to adeno, with objective response rate of 50%. And the new sacituzumab tirumotecan has objective response of 58% in phase 2 trial. To be honest, sitting in a gynae session, I thought I was sitting in a breast session. I'd forgotten to go, so it's all merging together. So, it is, after all, linked. So endometrial cancer was even more interesting. So I'll start off with this before I go on to the trial. So the romance with HER2 and endometrial cancer has been going on for a long time. I remember in 2004 when we were doing the HERA, gynae people were talking about, okay, endometrial cancer is next because it's also a hormonal cancer. But surprisingly, a couple of years later, the first phase 2 trial was negative with Herceptin and with trastuzumab and endometrial cancer. Then came the TAPER trial a couple of years ago, which was a basket trial, and that showed impressive benefits for endometrial cancer. And hence, the trial ongoing, trying to add in carboplatin, paclitaxel plus trastuzumab, pertuzumab, with the background suggestion that, it's and HER3 is the pathway in endometrial cancer that it goes through. So this was another impressive poster, trastuzumab deruxtecan, with the response rate of 58%, and for a +3 immunohistochemistry, 85%. Quite impressive. And again, similar SASI with a smaller than cervical cancer, but still response rates. And mirvetuximab, which is generally a platinum-resistant ovarian drug, alpha folate blocker, has also shown response. So how are we doing for time? So that I know what rate is it?
I think
What
we
do
are okay with the time at the moment.
Okay, excellent. So this is, I'll call it B21, ANGOT EN11 GOG 3053 was a phase 3 trial which looked at pembrolizumab and placebo in combination with adjuvant chemotherapy with or without radiotherapy in patients with newly diagnosed high-risk endometrial cancer. So last year, if you're listening to ESMO and ASCO, it was all about endometrial cancer and immunotherapy. This year, it was mainly cervical cancer, but there was this very interesting B21 trial, which we were waiting for actually for some time. And this was the third interim analysis with 1,000 patients. So endometrial cancer incidence is rising. Obviously, we know that all increased metabolic disorders, increased obesity, blah, blah, blah. In the first line, advanced cervical in the metastatic or recurrent setting, pembrolizumab added to, okay. Sorry about that. So in the first line, metastatic or recurrent settings, pembrolizumab and chemotherapy prolonged progression-free survival in patients with endometrial cancer. It was regardless of mismatch repair status in NRG GY018. I won't take the long name. So, and I'd refer to GY018 in future in this presentation. And the hazard ratio was 0.54 in MMR proficient, and it was even better at 0.30 in MMR deficient patients. So this GY018, they included patients who had residual disease after surgery or were recurrent or metastatic first line. While here we are talking in B21, our patients who were completely cured, completely resected. So the estimated 5 years disease-free survival is pretty good in endometrial cancer, 58% and 63%, following adjuvant chemoradiotherapy or adjuvant chemotherapy. So the standard, once you have the complete, for those of us, you who are not consultants and are still in training. So for early disease that have been completely resected, it's really concurrent chemoradiotherapy followed by chemotherapy like POTEC3 with 50 milligrams day 1 and day 21, followed by 4 cycles of carbotaxol after CCRT is finished, or sequential chemoradiotherapy, or GOG 258, which suggested just chemotherapy was equally beneficial with probably slightly more local recurrences. So that is the other option for completely resected endometrial cancer. And this is the area which they were trying to explore by adding in pembrolizumab. So B21 added, remember, in high-risk patients treated with curative intents with no residual disease. So eligibility criteria, slightly different from GY018, in that although it was newly diagnosed endometrial cancer, they were completely resected, but they also included carcinosarcomas, which were high risk, unlike the GY018. And there was no residual disease, and they used FIGO staging 2009, and high risk of recurrence, all that you see, patients that can get chemotherapy. So what are they? Standard non-endometrioid stage 1 and 2, standard any histopathology with P53 mutated, any stage 3 and 4A, those who have not had systemic chemotherapy. So they got carboplatin and paclitaxel 3 weekly for 4 to 6 cycle. This was followed in the experimental arm, included pembrolizumab with an experimental arm, followed by radiotherapy plus minus cisplatin, so either just radiotherapy or concurrent chemoradiotherapy, depending on the clinician. And they included pembrolizumab with the chemotherapy and pembrolizumab after the chemotherapy, whether they included radiotherapy or cisplatin or not. And the standard arm was just carboplatin paclitaxel with placebo. And the risk stratification was external beam radiotherapy or no radiotherapy, endometrioid, non-endometrioid, and staging, early and late stages. So MMR, again, baseline characteristics, well-balanced. Something to note, 35% were Asians, 58% were Caucasians, and the rest was, again, different ethnicities. Now, lymph node involvement in 41% versus no lymph node involvement, 55%. But interesting thing to note was 74% were MMR proficient. And this was deliberately included. It wasn't by chance. And this was what was planned. And 1/3 were MMR deficient. This was planned because with the positive GY018, which also included a lot of pMMR proficient patients, and that showed a good hazard ratio. So in GY018, there was quite an improvement for MMR proficient patients with a hazard ratio of around 0.54. So they were guessing that they might include that and might get a benefit. Again, early disease 1A, 2B, and stage 2 were around 35%. The rest of the stages were mixed. The stage 3B, 4B were excluded. Now, there was external beam radiotherapy with cisplatin, 75%, but without cisplatin. So half of the patients did not get chemotherapy after the chemotherapy finished, and it was a clinician's discretion. Again, endometrioid and non-endometrioid 50-50 nearly. Again, referring to GY018, majority of the patients were non-endometrioid in that trial. So, intention to treat population, disease-free survival shows a hazard ratio of 1.02. So no benefit whatsoever by adding the experimental group in the intention to treat population. So that was a disappointment because there was a lot of talk prior to it, and this trial was very much awaited. Now, protocol specified subgroups in the intention to treat population. If you look at most of the things, subsets, race, region, ECOG, lymph nodes, staging, they were all equal. But what is different here is the pMMR proficient patients had a hazard ratio of 1.20, so not significant. But look at the MMR deficient patient, hazard ratio of 0.31, which is quite impressive. So 69% benefit for those which added really immunotherapy to it. So again, this is how it's Kaplan-Meier curve. An MMR proficient patient, no benefit, whereas an MMR deficient patient, there was a 70% or 69% benefit by giving the immunotherapy with it, pembrolizumab. So although it's a negative trial, but there is a positive point here. And again, at the end, I'll ask what the obvious question is, what would the clinicians do here? So what about safety profile? Grade 3 to 5 toxicity, not a major difference, 70. So there was no new signals from GY018 here. A similar toxicity profile, if not better. 71% grade 3 to 5 toxicity, 63% in placebo. Grade 3 to 5 immunotherapy reactions were 10% as opposed to 2, but thankfully less than 1 death in the experimental arm versus 0 deaths in the placebo. So that was a relief. So summary, pembrolizumab to adjuvant chemotherapy. Again, I repeat, all the disease has been removed, no residual disease, improves disease-free survival in all-comer intention to treat population, in high-risk endometrial cancer after surgery with curative intent. In MMR deficient patients, the hazard ratio was 0.31. and MMR proficient, it's 1.20. Overall survival, not mature at the time of this interim analysis. Safety profile, manageable. And, it's a clinically meaning benefit, and as the author suggests, that it's a negative trial with a positive outcome. So I think, any questions here?
I would just like to ask, so do you think this will change the practice? Obviously, we have a good percentage of DMMR patients with endometrial cancers, or do we need to wait for another trial to prove it further?
So for MMR deficient patient, not just this trial. So let's talk about with residual disease. It's obviously, if you look at all the curves with durvalumab, dostarlimab, pembrolizumab, they're all the same for residual disease. So that's a game changer there. Now, here in early disease, you have this option of sequential chemoradiotherapy, POTAC3, and this is the third option here. So I think at this point in time, you'd really have to choose for MMR deficient patients. This is really one of them, the cohort of the all three. So I'm sure you'll get some patients who you don't want to give, with this more distant disease. You don't think giving concurrent chemoradiotherapy would be of much benefit. I don't know what you do in your practice, but we follow POTAC3. We don't generally give sequential unless it's a different histological type, aggressive histological type, or some other reason. So yes, I think it will be practice changing. I've actually given it to a few MMR deficient patients because looking at durvalumab, dostarlimab, it's been quite impressive results. So, and I'd like to hear from other people what they do.
Anyone would like to share their experience? Obviously, in NHS, we are quite restrained. We don't have access. But out of NHS, I think people can give it to the patients if they feel it will give them benefit.
Okay. Again, a question: how are we doing for time?
We have moved to variants. I think we started a bit late, so maybe we can stretch it a bit. I think we have got, I would say 10 minutes, and then we can take more questions in the end.
Okay, 10 minutes. So I'll rush through this one because this is an old one. And if you remember Prima, I'm sure everybody remembers Prima. This was final overall survival analysis presented this time. The preliminary analysis was 5 years ago, again in Barcelona, last time, presented by the same Antonio. I forgot he's got 3 names, so Antonio is how I remember his name. So quickly going through. So Prima really looked at newly diagnosed higher grade serous endometrial ovarian cancer after CR or PR to primary platinum-based chemotherapy. They were randomized to placebo or niraparib for 36 months. Primary endpoint was progression-free survival by blind independent central review, secondary by overall survival, and other secondary points were PFS2, time to first subsequent therapy, patient-related outcome, and safety. And overall survival was conducted at 60% maturity. So key characteristics are here. So I won't go through them. Everybody knows them. But these key characteristics, they resemble exactly how Paula were. They were high-risk disease with 99% stage 3, which had residual disease. So unlike Solo 1, which had early disease, this was quite aggressive, and a majority received neoadjuvant chemotherapy, unlike Solo 1, similar to Paula. So Prima 5 years ago, it met its primary endpoint in overall population and HRD both, with impressive hazard ratios. So this was an updated long-term progression-free survival. So progression-free survival was positive, and looking at the middle one, the HRD patients, the progression-free survival nearly doubled at 5 years from 16% to 35%. So good. HRP, again, it was proved in this study as well that HRT is bad population. And initially, there was some benefit in HRP population, but these proficient patients, really, a majority of them were dead in at this 3 years' time or so. So that confirmed that this is, or had progressed if they were not dead. So it confirmed their bad, you know, outcome. So this is the final overall survival. And at 62.5% maturity in overall population, there was no difference in overall survival between niraparib and placebo. And all the results were similar. Overall survival, no benefit. So that was quite strange. Because if you look at the solo one, good, population, not a very high risk population, overall survival benefit, 0.55. Looking at Paula, overall survival benefit, 0.62 hazard ratio. So possible explanations, I'd quickly go through them. These are the obvious explanations for any negative trial. But what I feel was, and what the author did not feel, but the critic of this trial suggested, but maybe they should have added bevacizumab. Sorry, admitting somebody late here. Okay. So the drug itself is unlikely because you look at all these four graphs. Is there any difference if I hid Prima, Paula, Sola 1? You won't be able to tell which progression-free survival that was for which trial. Nobody'd be able to say it. So the explanation given was that in the niraparib arm, in overall population, 66.7% of the patients had subsequent therapy, as opposed to placebo, 73.2%, which suggests that higher number of patients in placebo arm experienced disease progression than in the niraparib. So what about PARP inhibitors? So there was threefold higher PARP inhibitor used in placebo arm than niraparib across the population. And it was most predominant in the HRD population, mostly in the second line treatment. But here you look at all the PARP inhibitor trials, look at that, 44.3% in solo 1 and a PARP 14.6%. So yes, there was an imbalance, slightly higher, but could the difference of less than 50% explain the results? That's a big question. So my interpretation, obviously the conclusion is here. My interpretation is that they took, and of the critic as well, but not of the author, that they took the high risk population, but they did not have give anti-VEGF here. So Prima was a negative overall survival, positive progression-free survival. Is it still going to be used? Yes, there is certain cohort of patients, maybe in HRD where you can't give bevacizumab, because as you know, in Paula, you'd have to give bevacizumab for HRD positive, BRCA negative, and safety profile was tolerable. Another thing is 36 months is slightly a bit more. Maybe they need to reduce this, duration. So any quick questions?
Hi, sorry, can I ask a question? My name is Sushape, so thank you for the talk. Just to ask about this maintenance in niraparib, you've said that by looking at these trials, there's no overall survival benefit, but there's a few months, 3 to 4 months progression-free survival benefit, and there's a specific cohort of patients you still use niraparib for. Would you expand on that? Which kind of cohort of patient would you still use niraparib for? You said HRD positive, BRCA negative. Is that right?
Yes. So HRD positive. So what are the options do we have? So
sorry.
So we have olaparib. And, all for the availability of all the PARP inhibitors is not there in every hospital. So I would tell you what we do. What we have is olaparib and niraparib. So for patients who are BRCA negative, HRD positive, this would fall into a Paula 1 population, right? So for somebody who's unable to have bevacizumab for a number of reasons, for whatever reason, these are the patients that could have niraparib, despite the, whether you're a believer or not, whether you believe that, there was too much subsequent niraparib use, and that's why the overall survival should be positive or not, irrespective of that. So this is the one indication that I've we have in our hospital got it. If you can't give bevacizumab for a reason, and you don't have a third option for BRCA negative HRD positive, where you would normally give bevacizumab and olaparib, you could still, because of the HRD positive results, you could still give niraparib. So this was kind of a practical, proven practical point. Got it or not? Was I able to explain my answer?
Yep, got it. Thank you.
So, moderator, do we have something for a few minutes or some?
Yeah, we have a few more minutes. If you have any questions, please put it in the chat box, or you can raise your hands. But we haven't got any yet. Yeah.
Okay. So this will be a quick one. It's about immunotherapy. So Athena, everybody knows Athena. So Athena basically is a trial which comprises two components. There was a mono and this is a combo that I'm going to present. Mono was, and it was quite a, hyped up trial, because there's obviously, there is talk about immunotherapy, adding to PARP inhibitors, improving, expressing more PD-L1 because of addition of PARP inhibitors, and immunotherapy improving the immunogenicity, activating the cyclic AMP, GMP pathway, the STING pathway, so the obvious, and then came the DUO, which again, positive results, and this was presented last year. And before that, the Mediola trial, which is a phase 2 trial for the same drug, which was positive. So they were pretty hopeful that looking at a trial which would look at rucaparib in the Athena mono trial. So they took one of the arms of mono and continued that in combo, which is the arm of rucaparib, and added an investigational arm of nivolumab. So basically, 3 and 4 high-grade epithelial ovarian cancer, fallopian tube, peritoneal cancers, completed frontline platinum doublet chemotherapy and surgery, CR or PR, ECOG reasonable. They randomized them to rucaparib plus nivolumab. Arm B was just rucaparib. Arm 3 was an experimental arm of nivolumab alone, but this was not analyzed and will be analyzed at some stage. And arm D was, again, the placebo arm. So this treatment was for 24 months with a 4-week lead in rucaparib. So rucaparib was started a week before the nivolumab because there was a concern about abnormal liver function tests. And rucaparib, as everybody knows, is given BD, and nivolumab IV at 480 milligrams, and the other option was placebo. Baseline characteristics were well balanced. The interesting thing here was so 75% no residual disease versus 25% residual disease. BRCA was, they looked at BRCA positive and all the other molecular subgroups, and they used a loss of heterozygosity, which was positive in 43% and negative in 43%. And those who were positive, half of them were BRCA positive. PD-L1, they did not use the CPS score. In fact, they went on to use SP142 Montana antibodies. At a level of 5%, it was 15.8%, and greater than 1% were the majority. So anybody really positive for SP142 Montana antibody were included. So intention to treat population here, hazard ratio of 1.29. So it's not just even negative, but it's quite detrimental. If you look at single agent rucaparib with a median of 20 months versus combination rucaparib and nivolumab of 15 months. So very detrimental. I won't just even call it negative. It was. Have you ever seen a forest plot like that? All the subgroup, molecular subgroups, whether high BRCA positive or loss of heterozygosity high or low, or PD-L1 positive, all the molecular markers were in favor of a single agent monotherapy of recuperab. So then interim overall survival, again, recuperumab with placebo trumps with a complete negative result of hazard ratio of 1.13. So then they looked at the exposure really. So this was surprising results. So they said, okay, let's look at, let's find out why did this happen despite the DOO, despite the Mediola being positive. So here they suggested that rucaparib alone, in the alone arm, that it had 14.7, so there was 75% more exposure of the single agent rucaparib when given alone versus in combination rucaparib and niraparib only 75% less exposure to rucaparib was given. Similarly, nivolumab, 4.6% exposure as opposed to 11.1. So the first answer was by the author that the exposure was less. Safety population, obviously there were nivolumab side effects, you'd expect that. So it's combination of rucaparib with nivolumab does not improve progression-free survival, and it's a negative result. Obviously, then came the explanations by the critique. What could possibly be the explanation? So that explained the different PARP inhibitors. The explanation by the author was that discontinuation of the PARP inhibitor was more. Rucaparib in combination arm had more discontinuations. But then if you look at all these discontinuations, it was pretty high. And yes, 25% discontinuation in the Atino combo is quite high, but the difference of only 10%. Does that explain a negative results? We don't know. And I think finally, I'm running out of steam and we're finished. Thank you for listening.
Thank you so much, Dr. Durrani, for such a very good elaborated update on ESMO and for all your time. Thank you, everyone. If you have any questions, please raise your hand. Yeah, Dr. Khizr, yes, please.
Sajid, assalamu alaikum. So I listened to all your presentation with kind of interest. So I just want to make some points or comments really on the cervical cancer to begin with. I think we are in the era now that we are moving from radiotherapy to chemo, the interlace, and now we got the pembro. So I think the smartness for us as a clinician is, and maybe whoever is in the audience about trainees, that we need to be careful when we discuss in the tumor board which group of patients we offer which therapy or which regimen. So for instance, there are still group of patients which can very effectively be treated with chemoradiation alone, for instance. So as you said, interlace, I think they did not include bulky disease or did not include paratic nodes, especially above the renal hilum. So what I'm trying to say is that there are a group of patients we can effectively treat with chemoradiation alone, because over the years, radiotherapy has evolved and we are able to deliver quite higher dose, not to the tumor only, but to the bulky nodes as well. But I think the way I look at it is that if there are bulky nodes, when I say bulky, say more than 2 centimeters, we need to bring in additional treatment other than chemoradiation. However, my experience with interlace in the last year or so, the problem with interlace is that these people, when they have 6 cycles of weekly chemo, and by the time we start chemoradiation, they start having problem with thrombocytopenia and low blood counts. So I think here is a challenge that I think some of these patients we are probably over treating it. So personally, I'm not very impressed with the interlace. There are still group of patients such as bulky disease. I think induction chemotherapy has role to play. So those are the one which perhaps we should consider because it's high risk of distant disease. Pembro study is very interesting. So again, perhaps we need to select the patients which would benefit from adding Pembro. But let's not forget that we have three approaches now: chemoradiation, induction chemo, and Pembro. And I think the Pembro, if I were to kind of understand correctly, patients who are high risk, of course, but perhaps not very bulky nodal disease to begin with, those are the one I think perhaps would benefit from Pembro because you are giving Pembro after finishing your chemoradiation as well. So anyway, this is just kind of my observation and experience I'm just trying to throw in. But I think once you attend, the problem with these new developments is that I think we just have to be very careful changing the practice. If you were to say, Sajid, that the Pembro trial is now changing practice, I think we just have to be very careful which group of patients we should include in that. Thank you.
Thank you, Khizr. Very valuable comments coming from experienced person. So completely agree. You'd have to select your patients. So there are a couple of things. Immunotherapy is an expensive drug. And although interlace did not include many Asians and A18 did include Asians, still, a lot of Asian countries, you'd have to buy immunotherapy privately. Secondly, yes, we were using interlace and there was a lot of toxicity. And if you look at the demographics, interlace excluded patients with, those who've had hydronephrosis. And as everybody knows, for trainees, cervical cancer is one cancer, unlike endometrial ovarian, which if you do the local control, if you get local control, the overall survival benefit is there. Getting local control with endometrial and ovarian does not confound into overall survival, while cervical cancer, it does. So in interlace, they excluded hydronephrosis and this ovarian cancer commonly goes locally into the perimetrium and does cause hydronephrosis. So giving platinum-based chemotherapy, this is one thing we have to look at. So rest, the same as Khizr suggested, that it has to be, bulky disease, para-aortic, above the aortic bifurcation, and higher stage. So, what maybe I'd throw a bit of a mad statement. Maybe we need to include, interlace and A18, combine them both. So in future. Thank you.
Thank you, Dr. Khizr. So I would just like to, I know we are running out of time, but I would like to just ask one question. So with regards to the BEAT-CC, where they gave atezo and bevacizumab along with the chemotherapy in irrespective of the PD-L1. So if you have got access to Pembro and this regimen, which group, which treatment would you prefer, and which group of patients would you give this treatment specifically, atezo or Pembro?
So there are a couple of things. Are you saying if I had a choice, irrespective of what is really approved or not, or are you saying that I have to stick by the approval? So the answer would be different as opposed to.
If you have access to both, what would you recommend?
So if I had access to both and just looking at the trials, although I have not used it, we've been using pembrolizumab only. But if you just look at the trial, the Keynote 826 or the Keynote 158, where the FDA approval was, they got approval for CPS greater than 1, remember. And EMA approved a different immunotherapy, sapanumab, which we don't have, irrespective of immunotherapy. And, you know, in the exploratory cohorts, they have suggested that whether it's PD-L1 positive or negative, the benefit is there. So if I stick to whatever is approved, there is more evidence for atezo as opposed to pembrolizumab at present, because of solely because we don't know what happened to those 40% who did not have bevacizumab in the 8-6 arm. Secondly, approval was for only PD-L1 positive or immunohistochemistry positive patients, while here, this is the first trial that looked at PDL, not just PD-L1. That was PD-1. This is PD-L1, but looked at number one, irrespective of PD-L1 status. Number two, everybody got bevacizumab as long as they didn't have the bladder or bowel involvement. So long answer, but it would vary as to how my hands are tied.
Thank you. We have got a question. So post immunotherapy or atezo in metastatic cervical cancer, what will be your preferred second line?
So I showed them that there is an FDA approval and MI is considering, and I wanted to add that in the lecture, but it was, so tisotumab, it's a drug antibody conjugate. Tisotumab is one of the drugs that has been approved by FDA. So that would be my second line. And then the third line obviously is, TDXD for at least immunohistochemistry +2. So that was the poster I showed after cervical cancer. I don't know how to, maybe I'm able to get it up here. So these were, for the sake of time, I did not include them in the full lecture, but these were pretty impressive. So tisotumab vedotin would be my second line after immunotherapy, and then trastuzumab deruxtecan for those who have had at least a +2 immunohistochemistry. And as I said to you, this is becoming like breast cancer. If you do breast cancer, that's how we go about TDXD and SASI after. So, listening to one of the lectures, I thought I was actually mistaken. I was in the wrong session.
Great. Thank you. Just to say, we have got an evaluation form. It's in the chat box. You can go on the website, or you can send it on info@bpca.uk. And CPD certificates will also be provided to the attendees.
Yeah, if I may come in here, Sajid, with your permission,
Yes,
we
please.
will be doing, apart from evaluation forms, I think I have put a message out. There are lots of colleagues attending from outside UK. We may not have their details. So all we need is their email, so we can email them the CPD certificate. So if people can just email their information, we know who has attended, but we may not have their detail to contact to send certificate. So anybody who is coming to Pakistan or any other parts, please just email on info@ppca.uk and we'll send you certificate after that. Other one will be that next Saturday we'll be doing lung cancer meeting. So we'll be covering both advanced and early lung cancer. Next Saturday, which is 19th, 26th, we'll be doing melanoma. Following week, we'll be doing urology, and following we'll be doing GI. So it's a weekly program going on for the next few weeks. Hopefully, we'll try to cover as many tumor sites we can. Please do join in, and hopefully you will get something out of these meetings. Even though all the medicines discussed may not be available in your area practice. So thank you for your participation today.
Thank you, Dr. Bhatt, for and all of your team for creating this platform. I think it's a great initiative, and obviously we all learn and refresh and try to improve our knowledge and obviously the outcomes for the patients. So I think it's a great initiative.
Thanks. With that note, thank you, Rafia, for sending your details and filling the form. We will then close the meeting today if there's no more questions. So we'll see you next Saturday again. Apologies for the little IT issues in the beginning. We will send the meeting codes, make it a bit easier to log in next week. We'll see you next week. Thank you.
Thank you very much. Thank you.
Thank you, Dr. Durrani. Thank you.
Thank you for your invite.
Thank you, Sajid. Lovely work.
Still in Bahamas, huh?
Still in Bahamas, Aldeska.
We are jealous, Ajaz, looking at the background. Really jealous.
Yeah, I know it's just the background. Had I been
Especially sitting in the desert, I can see beautiful scenery on the back.
Yeah, I know. See people.
Enjoy.
We'll catch up next week. You're okay, Khizr? Alhamdulillah.
Yeah, thank you.
You look well.
I'm good. Thank you very much. Thank you.
Good.
Good to see you.
Stop